Hi, I'm Dr. Ralph Weiche, and it's the end of 2024, and I wanted to give you an update on our stroke protocols at the hospital. So recently the hospital has standardized their stroke protocols into 3 different categories, and I want to talk about what those categories are. The first one is the acute stroke patient, and nothing has changed with that category. Those are our patients who are eligible for thrombolysis if we can get him here and be evaluated and get thrombolytics within 4.5 hours of symptom onset. So those are probably our most time critical patients that we take care of, where they are literally losing millions of neurons every minute. So those patients will come in code red, and the procedure for that has not changed. There's 2 new categories that I'll talk about. One is a stroke standby, and those are the ones who have had symptoms within 24 hours, and the other one is a wake-up stroke that I'll talk about. So one of the most important elements in any of the stroke algorithms is to know when the last known well time is. And so the last known well time is the time when they were last normal or at their baseline. When you are assessing a patient, it'll be imperative that you get the last known well time, and when you call the NTL, you let them know when the last known well time is. And before you leave the scene, I want you to get the name and the number who gave you that time, because we are going to call and confirm that last known well time. Studies have shown that 58% of the time, medics get the last known well time wrong, and in reality, the time that they were last known well was earlier than what they say, which means that the patient would have inappropriately got thrombolysis, placing them at risk for intracranial hemorrhage. So the first category is the code strokes, and nothing has changed with our code strokes. So the code stroke are the ones who are eligible for getting thrombolysis within 4.5 hours of their stroke. Of all the things we do, treating a stroke is probably the most time critical thing we do, as millions of neurons are lost every minute. So if you have a code stroke, we want you to come code red. You'll be greeted at the door, and the patient will be assessed right outside the door, and we'll decide whether we want to continue with the code stroke. And they'll immediately go down to the CT and get a CT and a CTA and be evaluated as whether they're a candidate for thrombolysis. So the stroke standby is any patient who develops symptoms within 24 hours. So if you have a patient who has a positive BFAST exam and you believe that they had a stroke with their last known well time within 24 hours, then those patients will now come in as a stroke standby. And this is a new protocol for us. So if you have a patient within 24 hours, you want to, and you call in, you let the NTL know that, and you will be greeted at the door just as you do with the acute stroke, and they will go directly down to the CT scanner and get their CT and CTA. What we're looking for in those patients is to see if they have a large vessel occlusion. If they have a large vessel occlusion, then those patients are candidate for thrombolysis, and they will be transferred down to Harborview for thrombolysis. The goal is for that to happen door in, door out in less than 90 minutes. Those patients don't have to be transported code red unless the traffic is such that it's going to slow you down for multiple minutes. Then code red might be appropriate. Otherwise, they don't need to come code red. If they're being transported by ALS, I would like you to place a 20 or an 18 gauge IV in the right AC for their CT. Whether they're BLS or ALS, if you have time, I want you to get a rhythm strip or an EKG to find out if they're in atrial fibrillation. That will help us assess their risk of whether they actually had a stroke or not. But the IV and the rhythm strip should not delay their transport. They should still get here as expeditiously as possible. So the third category of patient are the wake-up stroke patients. So these are the patients who went to bed and they woke up with symptoms. Technically, the last known well time would be when they first went to bed, but you don't know, did the stroke happen 8 hours ago or did it happen 30 minutes ago? we can tell based on an MRI scan whether they potentially had their stroke within the 4.5-hour window for consideration for thrombolytics. So in the wake-up stroke patient, where somebody woke up with stroke symptoms and their last known well time was when they went to bed, we would consider those patients in this category of wake-up stroke. So for those patients, what we're looking for is whether they will be candidates for thrombolysis within that 4.5-hour window. So if you have a wake-up stroke, when you call to give report, let them know that you have a wake-up stroke. What will happen in that case will be just like with the other ones. They'll show up at the door, we'll get rapidly assessed to decide whether we're going to continue with the stroke protocol, and they will go down to the CT scanner and get a CT and a CTA. If they have a large vessel occlusion, they'll be transferred down to Harborview and they'll get thrombolysis. If they don't have a large vessel occlusion, then we can do an MRI scan, and that will serve as a proxy for telling us whether they are within the 4.5-hour window for thrombolysis. So we can tell by looking at the diffusion weighted image and the T2 image on their MRI scanner whether this stroke was acute. If it was acute, then they would be a candidate for thrombolysis and they would get TNK here at the hospital. So those patients also need to be transported emergently so that we can have them assessed within that 4.5-hour windows. The challenge is going to be that these patients need an MRI, and an MRI takes much longer to get, and the studies often take 2 hours for the type of studies we do, which means we'll have to take the current patient out of the scanner, put our patient in the scanner, and the imaging takes a while. So it's even more imperative that we try to assess these people as quickly as possible to try to get them within the window. If you have any questions about whether your patient might fit into one of these categories, you of course can always call either the STAR doc or the NTL, and they will help guide you as to whether they feel like these patients, your patient, is a potential candidate for one of these interventions. I hope that answers your questions and you are updated as of the end of 2024, and we will continue to keep you updated. Thank you very much for what you do.